And now we have our third speaker, PAH drugs in children. I guess everyone would be interested in learning about this. Dr. Navneeta Sasikumar from Kochi. Welcome, Dr. Navneeta.
Thank you and good afternoon, everyone. So the next few minutes, we'll be looking at the pediatric aspects of the anti-pulmonary hypertensive therapy. There would be significant overlaps with the last two talks, but I've tried to focus as much on the pediatric aspect of it. So grossly, treatment in children, we can look at two different aspects: conventional and supportive therapy and specific anti-pulmonary hypertensive treatment. Conventional therapy is diuretics, anticoagulation, digoxin, and oxygen. So diuretics, as we all know, when there is overt heart failure, it will be helpful. Also, it is beneficial in PAH related to diastolic dysfunction, which is rare in children compared to adults. Caution, because diuretics decrease preload and these patients are highly preload dependent for cardiac output, so it should be used judiciously. Digoxin can be given for patients with right ventricular dysfunction or overt heart failure. Chronic anticoagulation in PH patients, but it's not studied extensively and it is not routinely recommended in pediatric patients. There might be a subgroup of older children or adolescents with idiopathic pulmonary hypertension which may benefit from the same, especially those with indwelling catheters or those with ventricular dysfunction and thrombus or hypercoagulable states or chronic thromboembolic pulmonary hypertension. Oxygen supplementation is recommended in children with pulmonary hypertension and resting saturations less than 92%. Even home oxygen can be used in these patients. Particularly helpful in patients with an element of parenchymal or interstitial lung disease like in bronchopulmonary dysplasia, which is pretty common in these days. Coming to specific anti-pulmonary hypertensive treatment, the goals are to improve quality of life, improve hemodynamics, halt the progression of disease, and increase life expectancy is already discussed. As in adults, an acute vasoreactivity testing is recommended in children as choice of therapy. So in children, the BAS criteria is used for determining vasoreactivity to select treatment, first-line treatment modality. As opposed to adults, where Sigborn criteria is more commonly used. It has to be remembered that this criteria is different from the criteria that we use for operability assessment in shunt-related pulmonary hypertension. So the percentage of responders depend on the criteria used and the subtype of PAH. Improved survival has been reported in responders compared to non-responders in multiple studies. So amlodipine, nifedipine, and diltiazem are the recommended calcium channel blockers to be used in the responders. Children less than 1 year of age, this is not recommended, and increased right atrial pressures, right ventricular systolic dysfunction, and or overt heart failure is a contraindication for starting calcium channel blockers. They are all started at low dose and gradually titrated up. So these patients should be monitored closely like any other patient. They could deteriorate over time and might need an add-on or switch to other drugs when they deteriorate. As already discussed, the advanced PH therapy targets either of the three major pathophysiologic pathways involved in pulmonary hypertension, which is either the endothelial pathway, the nitric oxide pathway, or the prostacyclin pathway. Targeted therapy improves hemodynamics, increases functional capacity, and also improves survival in pediatric patients. In recent data from specific pulmonary hypertension centers, survival of up to 80% at 7 years have been reported in the current era. It is important to remember that historical data showed dismal prognosis in pediatric patients with idiopathic pulmonary hypertension. And this is a significant improvement that has been possible with the advent of newer drugs. So therapy, as already discussed, is guided by risk stratification in children as well. Clinical as well as investigation parameters can be used for risk stratification. Clinical criteria that are helpful include evidence of RV failure, progression of symptoms, presence or absence of syncope, affection of growth, WHO functional class. Investigations that are helpful include serum NT-proBNP and various echocardiographic parameters. Invasive hemodynamics from cardiac catheterization study are also very helpful in risk stratification. So for the higher and the intermediate risk patients, combination therapy is recommended in children as well, although the data is not as robust as in adults. So the rationale for aggressive early combination therapy is to tackle different pathways to attempt to halt the disease progression. So in very high-risk patients, ideally a prostacyclin should be included in the combination therapy. In the low-risk patients, monotherapy can be started and they can be closely monitored. The superiority of combination therapy with respect to survival has not been proven by prospective studies in children, but there are retrospective data to this extent. And it is important to note that this benefit was irrespective of whether the combination included prostacyclin analogues or not, which is very important in our context where it is difficult to get these medicines. So a strategy of goal-oriented therapy versus deterioration and then escalation. So when you compare these two, a goal-oriented escalation of therapy is more important. This is easier to do in adults where 6-minute walk tests can be used as one of the markers of or goals. In children, because there is the 6-minute walk test is not standardized and sometimes it is difficult to do in smaller children, the goal-oriented titration might be a little difficult compared to the adults. Coming to the drugs, already discussed, but I'll go to the pediatric aspects. So, sildenafil is one of the commonly used phosphodiesterase inhibitors in children. It is started in low doses and gradually titrated up. There has been a maximum limit warning from the FDA at 20 milligrams thrice daily. This was after the START2 trial, where a higher dose sildenafil was found to be associated with a higher mortality. So the adverse effects are mostly related to the vasodilatation and includes flushing, nasal congestion, epistaxis, hypotension, etc. In the START1 trial, serious adverse effects like stridor and ventricular arrhythmias were fortunately rare. It is important to note that very rare complications have been reported in premature infants, including vision and hearing loss, and hence use in these populations should be very cautious. Tadalafil is another phosphodiesterase 5 inhibitor, but the safety and efficacy data in children are limited. Intravenous sildenafil is particularly useful in the intensive care unit in critically ill pediatric patients, especially those with an unsatisfactory response to inhaled nitric oxide. It reduces PA pressure, shortens time to extubation, and ICU stay in children with postoperative pulmonary hypertension. Coming to endothelial receptor antagonists, bosentan, dual ETA and B antagonist is a predominantly used one in children. Again, it is started at a low dose and gradually titrated up based on the weight of the patient. Adverse effects include nausea, vomiting, abdominal pain, headache, flushing, edema, and nasal congestion. It is recommended to monitor liver function tests as well as blood counts monthly. Liver enzyme elevation is less in children compared to adults. Teratogenicity and male infertility have been concerns with the endothelial receptor antagonists. In women of childbearing age, it is important to exclude pregnancy and discuss regarding contraception while using endothelial receptor antagonists. Ambrisentan and macitentan are other endothelial receptor antagonists. Ambrisentan is a highly selective endothelial receptor A antagonist, while macitentan is a dual antagonist. Compared to bosentan, macitentan penetrates deeper into tissues and binds to ETA for longer compared to bosentan. There is limited data for both in children and the use is off-label. It has been used in children more than 12 years of age. Compared to bosentan, liver enzyme elevation has been less, but still periodic monitoring is recommended. And the same concerns for teratogenicity and male infertility remain with these two as in bosentan. Coming to prostacyclin analogues, they bind the IP receptors, increase cyclic GMP, and mediate vasodilatation. They also have antiplatelet, antithrombotic, antiproliferative, and anti-inflammatory properties. Prostacyclin therapy, as mentioned previously, was a landmark in PAH treatment. It revolutionized the natural history by increasing life expectancy and improving quality of life in both children and adults with pulmonary hypertension. The preparations include epoprostenol, treprostinil, and iloprost. The cost as well as logistics of the intravenous administration, the subcutaneous administration, as well as the frequent inhalations might be a problem even when they are freely available when we consider our settings, especially in pediatric patients. Newer drugs, triosiguat, as discussed, is a soluble cyclic GMP direct stimulator. It has been found to be useful in adults, and it is the first FDA-approved drug for chronic thromboembolic pulmonary hypertension, but pediatric experience is limited. And importantly, it should not be combined with phosphodiesterase inhibitors because of profound hypotension. Selexipag, again, discussed in depth, and limited data in pediatrics, but in small studies, it has been found to have favorable outcomes as an add-on therapy. And some special situations in the pediatric setting, assuming the multiple small studies, it has been found that sildenafil as well as bosentan has been beneficial. In adolescents and young adults, bosentan is recommended as the first line. In children, either bosentan or sildenafil is used as the first line therapy. The target is to aim for the best possible functional class and add on the second drug when it is not met. Fontaine, another special situation in pediatrics, multiple small studies have noted benefit of sildenafil as well as bosentan in symptoms, functional class, and carefully selected patients with Fontaine. It is important to remember that not all Fontaine failure is due to increased PVR, but in selected patients with PVRI more than 3 wood units meter square and transpulmonary gradient more than 6 millimeters of mercury, either an endothelial receptor antagonist, a phosphodiesterase inhibitor, or inhaled iloprost is recommended to improve exercise capacity. It is just a class 2A recommendation. This has to be further studied in prospective trials. And that's all. Thank you for your patient listening.